A routine visit, e.g., for hypertension or diabetes, often reveals underlying mental health issues, sleep difficulties, stress, lack of motivation. This highlights that mental health concerns frequently hide beneath physical complaints. The shift in healthcare perspective. Mental health intersects with every specialty, primary care, cardiology, pediatrics, etc. Complexity is rising. Chronic illness, social stressors, trauma, and psychological distress are intertwined with physical health. NPs are responsible for whole person healthcare, recognizing that mental health affects treatment adherence, symptom perception, and outcomes. Prevalence and impact. Data context. Millions of U.S. adults experience mental illness annually, including serious conditions, MDD, PTSD, schizophrenia, bipolar disorder. Sustained levels. Anxiety and depression rates spiked during COVID-19 and remain elevated due to financial stress, social pressures, and uncertainty. The NP's role. NPs are often the first clinicians to encounter emerging symptoms, placing them in a critical position for early recognition. Clinical reality. Even when the chief complaint is purely medical, e.g., pain, GI issues, mental health factors often act as hidden drivers of health outcomes. Global burden and changing landscape. Mental disorders account for a significant share of the global disease burden dailies, with depression as a leading cause of disability. Mental health concerns are increasingly part of routine care. The percentage of adult primary care visits addressing mental health has risen from 10% to nearly 16%, showing that these conversations are no longer confined to behavioral health settings. Hidden presentations and comorbidity. Mental health often appears indirectly through somatic symptoms, fatigue, chronic pain, GI complaints, insomnia, or subthreshold symptoms that still impair functioning. Significant share of the global disease burden dailies, with depression as a leading cause of disability. Mental health conditions frequently coexist with chronic illnesses, diabetes, cardiovascular disease, chronic pain, COPD, creating bidirectional effects. Depression can reduce treatment adherence, worsen disease control, and increase complication rates. Anxiety can amplify symptom perception and drive higher healthcare utilization. Depression acts as a risk factor for poor medical outcomes, comparable to smoking or uncontrolled hypertension, and is linked to increased mortality, hospitalization, and morbidity. Impact on utilization and adherence. Patients with co-occurring mental and physical health conditions have higher rates of unplanned healthcare use, urgent care, ED visits, hospitalizations, and require complex care coordination. Adherence challenges are common. Depression reduces motivation, anxiety fuels avoidance, and stigma discourages disclosure, leading to missed appointments, early discontinuation of treatment, and disengagement. Practical implications for NPs. Managing these patients can feel overwhelming without structured workflows. Health systems are increasingly adopting screening protocols, follow-up systems, and referral pathways to behavioral health. Anticipating adherence risk, building and structured follow-ups, and maintaining open communication are key strategies. Maria, she is a 54-year-old woman who presents to primary care for a follow-up related to type 2 diabetes, hypertension, and chronic low back pain. During the visit, she reports persistent fatigue, more sleep difficulty concentrating, and she also mentions feeling really overwhelmed by trying to manage her health conditions, but when asked directly about depression, she responds by saying something that many nurse practitioners have heard before, quote, "I just need to push through over the past year." Her A1C has increased, and she has missed several specialty appointments. At first glance, this may look like a fairly typical chronic disease management scenario. When we take a little bit more of a deeper look into Maria's situation, we begin to see a broader context. She lives alone and works part-time while serving as a caregiver for her mother, which also adds that additional stress and responsibility. Recently, Maria has experienced financial strain, increased caregiving demands, and limited social support. In terms of healthcare utilization, she frequently visits urgent care for her pain flares. Her primary care provider has noticed that she seems somewhat withdrawn during her appointments. None of these details individually confirm a mental health diagnosis, But together they begin to suggest that something more may be going on beneath the surface. Maria's care team already includes several healthcare professionals. She sees a primary care nurse practitioner, a pain management specialist, a physical therapist. She goes to an endocrinology clinic and occasionally works with the social worker from a medical standpoint. She has the primary comprehensive care team that's fairly robust, but there's an important gap. There has been no behavioral health involvement yet. And that is something that we quite often see in practice. Patients may be connected with multiple medical services that the underlying mental health concerns have always remained unrecognized or unaddressed. This case will help us illustrate how mental health awareness can influence patient care. Stigma as a barrier to care. Even though mental health concerns are common and significantly impact medical outcomes, many go unrecognized or untreated. Stigma is a primary reason. Stigma operates at multiple levels. Public stigma, societal stereotypes and discrimination. Self-stigma, internalized shame, embarrassment, or fear. Structural stigma, policies or organizational practices that create barriers to mental health care. Provider stigma, implicit or explicit biases that influence clinical interactions. Impact on patient behavior. Help seeking. Stigma reduces willingness to seek professional support, leading to delays in care and underreporting of symptoms, e.g., patients discuss fatigue or stress but avoid mentioning depression or anxiety. Disclosure. Patients often conceal symptoms due to fear of being judged or concerns about how information will be used, e.g., in medical records, employment, insurance. Disclosure is strongly influenced by perceived safety in the therapeutic relationship. Treatment engagement. Stigma can lead to lower acceptance of treatment, early discontinuation of medications or therapy, and disengagement from care. Role of healthcare systems and providers. Structural factors, such as limited behavioral health services, complicated referral pathways, long wait times, and inadequate insurance coverage, reinforce stigma and discourage patients from seeking care. Provider communication matters. Even subtle stigmatizing interactions can deter patients. Implicit biases may affect how symptoms are interpreted or prioritized. Reflective practice and open, non-judgmental communication can significantly improve trust and patient willingness to share sensitive information. Intersectionality and cultural context. Stigma is not experienced equally. It is compounded by cultural, racial, social, and identity-based factors. Marginalized communities, youth, rural populations, and gender-diverse individuals often face unique barriers. A tailored, culturally responsive approach is essential to support engagement across diverse populations. Stigma is modifiable. Educational interventions, bias awareness training, and structured stigma reduction programs improve attitudes among healthcare professionals. Contact-based learning, hearing from individuals with lived experience, is particularly effective at humanizing mental health conditions and reducing stereotypes. Reducing stigma leads to better patient engagement, trust, and ultimately improved clinical outcomes. Creating psychologically safe clinical spaces. Small communication changes can significantly reduce stigma. Use person-first language, e.g., a person with depression rather than a depressive. Normalize mental health conversations during routine visits to signal that these concerns are welcome. Practice empathy and active listening. Feeling heard increases disclosure. Employ shared decision-making to reduce power differentials and foster collaboration. The clinical environment, time pressure, room setup, interruptions, can subtly affect how safe patients feel sharing emotional concerns. Reflection as a tool. Clinicians are encouraged to reflect on a patient who hesitated to discuss psychological concerns. What signals, body language, tone, avoidance, suggested discomfort or stigma? How might the environment have influenced the interaction? What could have been done differently? A different question, a validating pause, to open the door. The NP's role in reducing stigma. NPs are often the first point of contact for patients with both physical and emotional health needs. Addressing stigma aligns with trauma-informed care and patient-centered practice, emphasizing safety, trust, and collaboration. Reducing stigma leads to stronger engagement, improved adherence, and better long-term outcomes. Key takeaways on stigma. Stigma shapes clinical trajectories. It influences disclosure, treatment pursuit, and ongoing engagement. Stigma operates across multiple levels: individual, clinician, system. Stigma reduction strategies measurably improve patient engagement and therapeutic relationships. NPs can act as change agents through intentional communication, trauma-informed approaches, and supportive clinical environments. Transition. Recognizing stigma is only the first step. The next is translating awareness into practical, integrated clinical strategies that address both mental and physical health in a coordinated way. Case example, Maria continued. During a follow-up, Maria hesitates but shares. Shame about not coping better. Past experiences of feeling dismissed when discussing stress. Fear of being labeled and concerns about employment or insurance implications. Cultural beliefs that emphasize self-reliance. Her situation is complicated by fragmentation of care. Different providers see pieces of the puzzle, but no one has connected her physical and emotional health or conducted formal screening. This highlights the need for integrated approaches that bridge communication gaps and coordinate care across settings. Moving from awareness to action. Transitioning from awareness to intentional action requires structured strategies. Screening and interviewing help identify mental health concerns early. Use validated tools like PHQ-9, depression, and GAD-7, anxiety. Consider substance use and suicide risk assessments as well. Measurement-based care supports diagnosis, clarifies differentials, and tracks outcomes over time. Document mental health observations in the EHR, subjective history, and mental status exam, and use appropriate billing to reflect this work. Normalizing and destigmatizing conversations. Incorporate mental health discussions into routine visits using empathetic, non-stigmatizing language. Use person-first language and normalize that mental health is part of overall health. Trauma-informed care as a universal precaution. Assume every patient may have a trauma history. Use universal precautions just as with infection control. Principles: safety, trustworthiness, collaboration, empowerment. Engage all staff, e.g., administrative, in trauma-informed practices to avoid re-traumatization. Suicide risk awareness. Suicide screening belongs in all clinical settings, as many individuals who die by suicide saw a medical provider shortly before. Use tools like the Columbia Suicide Severity Rating Scale, CSSRS, to guide risk assessment and safety planning. Asking about suicide and creating a safety plan is a life-saving intervention. Overcoming barriers. Common barriers: time constraints, limited access to behavioral health resources, patient complexity, and stigma. Strategies: focus on collaboration, implement routine screening, and establish structured follow-up systems. Enhancing engagement and adherence. Schedule regular, close follow-up to monitor progress and reinforce engagement. Address social determinants of health, transportation, cost, support systems to reduce barriers and build self-efficacy. Use technology, telehealth and mental health apps, mood tracking, coping skills, mindfulness can support patients between visits. Managing complex presentations. Patients with multimorbidity, co-occurring medical, mental health, and substance use conditions benefit from more frequent follow-up, clear structured plans, and interdisciplinary collaboration. Clinician well-being. Addressing mental health in practice can lead to emotional strain and burnout. Support clinician well-being through reflective practice, self-care, team support, and regular check-ins. Monitoring one's own mental health improves sustainability, retention, and quality of care. Key takeaway: integrating mental health awareness into daily NP practice is achievable through intentional use of screening, trauma-informed communication, collaborative care models, and attention to both patient and clinician well-being. Key strategies for integration. Normalize mental health through routine discussion, screening, and use of non-stigmatizing language. Implement measurement-based care, e.g., PHQ-9, GAD-7, and structured treatment plans. Collaborate with behavioral health specialists to improve access and quality of care. Create psychological safety via trauma-informed care principles and suicide risk assessment/safety planning. Small changes, large impact. Simple, consistent actions, such as intentional screening, empathetic language, and regular follow-up, can shift clinic culture over time. Nurse practitioners are well positioned to lead in delivering high-quality mental health care, whether through direct treatment or coordinated referrals. NP leadership and advocacy. NPs can champion whole person care by driving screening and early intervention, coordinating interprofessional collaboration, advocating for stigma-responsive care, and influencing systems/policies. Interprofessional collaboration not only improves patient outcomes and adherence, but also enhances clinician workflow and satisfaction. Final takeaways. Mental health awareness is foundational to patient safety and quality care. Mental health concerns often present indirectly, somatic symptoms, routine inquiry, and screening are essential. Embedding mental health awareness into daily practice through stigma reduction, trauma-informed environments, and collaborative care positions NPs to make a meaningful, lasting impact. Case resolution, Maria. Her primary care NP used PHQ-9 and GAD-7 and normalized the discussion, allowing Maria to share how stigma had previously hindered her care. A team-based approach, NP, behavioral health clinician, social worker, pain specialist, was convened. Shared decision-making kept Maria as the expert on her own priorities. Outcomes. Subjective. I finally feel heard. Objective. Improved sleep, reduced fatigue, better mood, decreased PHQ-9 scores, remission. Downstream effects. Improved adherence to diabetes and physical therapy regimens, reduced urgent care visits. This illustrates that integrated, person-centered care leads to global improvements in both mental and physical health.